You're juggling it all: work, family, decisions, expectations, 6 hats, maybe more every single day. But behind the scenes, your body is running on stress, and stress left unchecked will lead to illness. I'm Dr. Shami, an integrated family doctor, and this is 6 Hats, the podcast that helps you understand what stress is doing to your body and what you can do about it now. Hello, everyone. Welcome back to the 6 Hats podcast. And today I'm really excited to have Dr. Romey Granek. She is a general surgeon here in Melbourne. She actually graduated from Monash University back in 2014 and is a fully qualified surgeon. We're going to dive into, because I think any woman who's doing surgery is just phenomenal. Her interests include Aboriginal health, and she runs this surgical outpatient clinic focusing in Aboriginal health. Which hospital, Romey? Actually, I forgot.
So it's actually the Victorian Aboriginal Health Service.
Wow, amazing. And you also have a special interest in acute general surgery, trauma, education, and system change. So it's going to be such an interesting conversation. So thank you, Romey, for joining us.
No, thanks so much for having me on.
Amazing, Romey. Do you know what? I'm always curious, have so much respect for women getting into surgery. At what point in your medical training did you go, yeah, this is what I want to do, surgery?
Yeah, it's a good question. When I think back through the very early stages, I immediately was drawn to anatomy, drawn to the problem solving and creativity that sort of surgery lends itself to, the practical skills. And I guess partly intuition, partly realizing that you can definitively cure something through surgery was very appealing. And also, I guess, a bit of naivety at the time.
Yeah, it's so rewarding, is it? When I speak to other women surgeons, it's like you go in, you cut it open, you remove the problem. Just so rewarding.
Yeah, I think over time I've realized actually preventative health is hugely more rewarding. But I think there's certainly a role for surgery as sort of in collaboration with.
Yeah, and I'm so curious, and I'm sure my listeners are. Literally, we hear things, stories, news about the tough training that you would have had to go through in what it was a male-dominated field. And I'm talking like when I went to med school, it was 25 years ago. So I've graduated for 25 years, and I awe of any women doing surgery at the time, because we were literally fearful of our consultant surgeons. And I did all my training in the UK. We were scared. We were literally scared. I remember going to the lectures and we're like, oh my God, that surgeon's going to be teaching us. And we would all be petrified, because at that time, that kind of culture was yelling and putting people down and, belittling students. And it was when I really think back, I really hope it's changed. And it's so interesting over time, as I see surgeons graduate and, going to private practice. And as a GP, you meet a lot of surgeons. I was like, wow, you're actually really nice. What happened? But do you think the culture has changed?
I think it's certainly changing. I was very fortunate going through. I did my training through St. Vincent's Hospital, had fantastic support and mentors. I've got to say there's definitely some female surgeons out there that are even more intimidating than some of the blokes.
Wow.
But I do really think the culture is changing. There's still a lot of work to be done. I think, empowering people to speak up, especially kind of evening out the hierarchy, I think there needs to be a lot more work in that space.
Yeah. And do you feel like that's a big issue, big egos, the culture of putting people down and not creating a safe environment for learning? Is that an issue?
Certainly it still exists. It's far less than what I remember starting off. I think a lot of it actually is driven by insecurity, fear of harming patients, making mistakes. There is an element of ego for sure, but I'd like to think it's more concern for safety, really. But yeah, for sure, it's hard to separate it. I think everyone has a lot of the ability to do a lot of introspection and self-development on their coping mechanisms with stress.
Amazing. So well done. And you're a fully qualified general surgeon. And I love the fact you're into education, hence why you're on this podcast, Rory, which is awesome. What's your vision in terms of educating the public with knowledge about surgery?
Yeah, I have a few ideas and projects on the go. It's interesting trying to provide education that's tailored to the audience is difficult. So one big project, I guess, that I want to do that I'm working on is creating a website called Journal Club, which is more tailored to people in the medical field, from medical students up to consultants, that aims to summarize clinically relevant research in general surgery in a really succinct and engaging way, sort of more like a newspaper style format. And I also have an idea of, down the line, a social enterprise type business where it's more about community engagement. And it's not necessarily just about health, but also focusing on various topics that allow people to network and become more informed in an inclusive space.
I love it. Love it. I love how creative you are. So interesting, because when doctors go through the medical training and come out, it can be so narrow focused. This is all we've got. This is all we got to know. And to be creative, it almost kills the creativity out of most doctors. So hats off to you, Romey. That's awesome. Keep sort of visualizing different ideas. That's awesome. Now, I know your special interests like acute general surgery, trauma, and we had a discussion. We were like, how can this really help our listeners who are mainly women, probably in their 40s and older? And so we decided to separate it and we go, right, anything gynecological, pelvic related, we're going to leave it to the gynecologist. Let's talk general surgery and let's go through a scenario where a woman, perhaps in their 40s, has suddenly got pain in their tummy and they turn up in emergency. They'll see someone like you, Romey. What do you do? What are you thinking? And what's so important to relay across to women?
Yes, I suppose my initial approach is always to do a quick assessment at the end of the bed to see how urgent this person requires intervention. And then my decision tree really depends on that. So if, ruling out all the life-threatening presentations quite quickly, if the person's talking and fairly relaxed, although in some discomfort, the next step is really taking a thorough history to try and find out what the likely source of the pain is and the contributing factors, as well as my mind always goes to, are they fit for surgery, essentially? And that really, it's interesting. I definitely allow the patient to tell their story because that provides so much information, more than any kind of closed questions that I can ask in the initial 5 to 10 minutes.
It's so great you said that because I remember at med school, this was years ago, 80% of the diagnosis comes from the history and why it's so important just to listen. And unfortunately, like in today's medical model or busy clinics, especially in the GP clinics, or that setting of 6-minute consults, we're actually not listening to the patients. We're not getting the story and we're going straight into diagnostic tests. We've almost forgotten that the true medicine of how much we can actually. And I actually remember doing a surgical tutorial as a med student, and a surgeon said 80% of your diagnosis is going to come from the story. And it's quite phenomenal. And then the testing just supports it or discounts it. So I'm glad you said that, Rory.
That's exactly right.
Awesome. So in the story, what are you looking for? What sort of the commonest presentation for women with sore tummy?
Yeah, so I would say, from what I see, it sort of depends whereabouts, but I guess in a 40-year-old female, things that spring to mind are gallbladder pathology, so gallstones, or cholecystitis, which is an inflammation of the gallbladder, and then bowel pathology would come after that, I suppose, or even stomach upsets, anything ranging from gastritis to the less common, fortunately, these days is peptic ulcers. But certainly, it just depends on how they've been recently. There could be viral illnesses, there could be anti-inflammatories they've been taking. Pancreatitis is another common thing. I guess there's just so many possibilities. I don't rule any of them out until I get a bit more of a background.
Yeah. Let's talk about cholecystectomy, which is like removal of the gallbladder and cholecystitis, because I actually see that so frequently.
Mm.
And it almost comes in a triad: cholecystectomy and then endometriosis, and periods issues. And then nowadays, what I've noticed is you can be slim and still have gallbladder issues. And remember the day past when we were studying and we go, right, that whole picture of the women is mostly, on the overweight side, that's a risk for gallstones, but it's no longer the case.
Yeah, it's interesting you say that. I guess gallstones form because of an imbalance in the different products that help keep the solution in the gallbladder, I guess, liquid. So if you've got an excess of cholesterol, for example, which you might see after rapid weight loss, dietary factors, often, a combination of environment and genetics. They're probably the most common reasons. As you say, slim people can certainly get gallstones. Could be an absorption issue. So you can see that with inflammation of parts of the small bowel that are important to reabsorb those bile acids. Medications also we're seeing increasing frequency in affecting absorption. And then I guess with the increased use of Ozempic as well with weight loss, people
Wow.
are forming gallstones as well.
Oh, can we just sidetrack and talk about that? So you're actually seeing that, and that's probably one of the questions you would ask.
I would always ask about weight loss. I'm not sure what the studies show specifically about Ozempic and gallstones, but certainly any cause of rapid weight loss. So post-bariatric surgery or people who manage to lose a lot of weight through dietary and exercise is super common. But there's been arguments about, or debates, I suppose, about whether to prophylactically or in anticipation remove a gallbladder, but that's not been proven to be effective for patients. So,
on a weight loss journey, because
correct. Yeah,
the incidence is quite high.
it is. But I suppose all surgery has risks, and not everyone who has gallstones will develop problems because of them. I think if you ultrasounded a lot of people, they'd probably have sludge or stones. It doesn't mean that they'll have symptoms.
And obviously, when you see them, they're in pain, in severe pain, to end up in emergency. So what will happen is often they'll probably see a doctor, GP, much earlier on, and it may just be this intermittent pain right upper part of the tummy, and it might just come and go. It can also be ignored. Would that be right, Romey?
Yes, I think a lot of people, have other commitments, work and kids and whatnot, and don't prioritize their own, well-being, which is totally understandable. But I would recommend if people are having even intermittent pain, chances of this going away fully is very low. And operating at a point where you're symptom-free is much safer than if you've got severe pain, indicates a lot more inflammation. And the operation, is very feasible in those settings, but you want to be as healthy and fit as you can be before you undergo the stress of the surgery.
Yeah. Let's go through the symptoms of gallstones. What would that sound like?
So it depends on why you're getting symptoms. So if you just have gallstones that sit in the gallbladder and intermittently sort of cause some irritation, especially if you're eating fatty foods, then you tend to, after a fatty meal, get some right upper quadrant pain, maybe a bit of bloating or fullness or a bit of nausea. And those symptoms shouldn't last very long, in the order of, say, a few minutes up to 30 minutes. But some people, it can last for a few hours or even be persistent and result in other factors like vomiting. In those cases, the stone may actually be stuck or causing a persistent blockage of the gallbladder. That's when the increased pressure of the gallbladder can really lead to problems.
And that's the severe pain, double up.
Also, you can pass stones down the natural duct, the bile duct that drains the gallbladder, and that itself can be very painful. But generally, if the pain goes away, it means one of two things. Either the irritation's gone because either the stone's passed or it's unblocked, or the inflammation has been so bad that now the gallbladder's not getting enough blood supply, or it's in fact perforated. But in those cases, generally you'll find the patient's very sick. They've had fevers, they're maybe a bit confused. But yeah, pain that's coming and going and then disappears doesn't necessarily mean a good outcome.
Great. And it's so important to seek medical attention.
Correct.
You do that. You also mentioned pancreatitis. So how is it related, to explain to the listeners?
Yeah, so the most common causes of pancreatitis are gallstones and alcohol. Both essentially can cause irritation of the pancreas through different mechanisms. So in the context of gallstones, a stone or sludge can come out of the gallbladder, and the pancreas actually drains into a common channel through the bile duct. So if you've got some partial blockage of that duct and the back pressure affecting the pancreas, the enzymes that the pancreas produces that help to digest foods, they irritate the pancreas and, in fact, digest some of the tissue itself, leading to inflammation.
Wow. And that pain, is that different to gallstones?
Yeah, people tend to describe it more as like a constant central pain that radiates to their back. And it tends to not come and go. It's persistent and generally would last a couple of days.
And as far as I'm aware, they're really unwell.
They can be, for sure. Fortunately, there's mild versions but generally people with pancreatitis, I haven't heard of many people who can tolerate this pain at home. They
Mhm.
generally present at some point.
Amazing. So when do you decide to remove the gallbladder as a surgeon?
So I always take in multiple factors. So I consider the patient, their symptoms, the urgency. So in an otherwise fit and healthy patient who's having symptoms from gallstones, it's generally indicated. Ideally, you perform this at a time where it's the safest. So there's different guidelines, I suppose. If the gallbladder is actually inflamed, so cholecystitis, the recommendation is to perform surgery within 72 hours. We used to delay it and wait for the inflammation to go, but we know that actually leads to worse outcomes. I tend to advocate for performing surgery early, even in the context of biliary colic, which is that intermittent pain. So I know delaying things, you just increase the risk of getting cholecystitis or even pancreatitis. In the context of if you have pancreatitis, you wait for the pancreatitis to settle down and then perform the surgery before the patient goes home from hospital.
Amazing. Amazing. And in terms of, and I know my listeners will be thinking about it. So what happens after surgery in terms of digestion? I always get that question.
Yes. So a small percentage do, in fact, get some intolerances to fatty foods, some bloating or nausea, but this tends to settle after some time. I think it's caused post-cholecystectomy syndrome. But I tend to see when I follow up these patients in clinic after about 3 to 4 weeks, most people say it's settled by then if it does occur. So I tend to advise just to sort of reduce the fat intake and dairy in the diet and just temporarily. And that seems to do the trick.
And what about diarrhea? I've heard a lot of.
Yeah, definitely. Diarrhea is also can be an issue. And again, it's hard to know, is that because we've removed the gallbladder? Is it because we've affected the gut microbiome with the antibiotics we tend to give, the food in the hospital?
That's true.
Yes, lots of options.
That's another conversation, right?
Yeah.
Amazing. So, and I often get this question. So what happens to the bile once you remove the gallbladder?
So fortunately, our bodies are very good at adjusting or compensating. So that main bile duct actually tends to dilate after you remove the gallbladder, and your body has impressive mechanisms to maintain the recycling of bile salts to ensure that we can still digest our cholesterol and fats appropriately.
So basically, instead of getting stored in the gallbladder, it goes directly into your large bowel.
Yeah, and I guess the production of the bile and the bile duct compensates for the lack of storage after you remove the gallbladder.
Awesome. And what's the recovery like after a cholecystectomy in the sense of how many weeks off work and when can they get back to driving and normal life?
Yeah, it does depend a bit on how complex the inflammation is and the surgery. But I would say in a standard case, most people, I mean, we're even doing day surgery now for these in an elective setting. So some people stay overnight or go home the same day. And generally I advise most people about 2 weeks off work. And it's a bit different for each person depending on what their work involves, heavy lifting or what kind of physical activity. Driving, we tend to suggest about 2 weeks. The main thing is we've cut through the strong connective tissue to be able to get into the abdomen to do the keyhole surgery. So if there was an emergency, you'd have to be able to brake safely. And unclear if some of the insurance companies will actually cover you if not within that sort of safety window. So generally I advise about 2 weeks, but we tend to ask the patient to see their GP and check in with them. And if they need a bit longer, we can certainly cover them for that.
Amazing. I've initially you mentioned you're really into preventative health. So is there anything women can do to reduce the risk of gallstones?
Yeah, so the general advice about healthy diet, maintaining a healthy weight, lots of water, but I suppose it's a mixture of both genetics and environment. So can't really change your genetics. But the environmental factors as general principles of staying healthy are the ones that apply here.
Amazing. Amazing, Romey. Thank you so much. So insightful. And I'm sure it's going to help so many people listening to this. Just that knowledge and that awareness of commonest presentation, which is actually gallbladder pain, which is amazing.
Yeah.
Amazing, Romey. Thank you so much. And I'm excited to see how your dreams come true in terms of creating those platforms and just spreading great knowledge. And you're so right. I love the fact that journal club, because to be honest, doctors just do not have time to read through journals, and we almost just need snippets someone to read, digest it, give us the main points. That makes so much sense. And in terms of your work in Aboriginal health, what have you noticed is the biggest difference in terms of presentation?
So I suppose I've worked a fair bit up in Darwin in the Northern Territory, and this is sort of a new role in Victoria in the outpatient setting, but I can speak to my work up in Darwin. I suppose a lot of the time patients are presenting much later with much more advanced conditions and far more comorbidities or other health problems that complicate their care. Then there's, I guess, all the cultural considerations surrounding family members being present, translators, difference in concept in terms of concepts around time, even like fasting time. Patients may have competing interests such as sorry business and things that really are a different framework to what I've been used to working here amongst the Western Victorian population. But I suppose gallbladder in an Aboriginal patient can be some of the toughest operations to perform.
Wow, for what reason?
I think it's a combination of just late presentation a lot of the time. They may have had multiple repeat episodes of inflammation that has gone untreated, and so the amount of scarring present and the rates are, this is more anecdotal, but the rates of not being able to remove the whole gallbladder, which we call a subtotal cholecystectomy, I think certainly much higher from my experience than what I've performed for non-Aboriginal patients.
Amazing, amazing. Thank you, Rory. And where can people find you? Are you on social media or do you have any online platforms?
Yeah, for sure. So I am on LinkedIn, on Facebook and Instagram, and it's all Romey.Granek. So feel free to look me up, send me messages if you want or any questions. My email also is romey.granek@gmail.com. So very happy to answer anything.
Wow, well done, Rory. Thank you so much for your time today.
Thank you.
Thanks for listening to Six Hats, where it's all about progress, not perfection. If this episode spoke to you, don't wait, hit follow now, leave a quick review, and share it with someone who needs to hear it. Want to take your next step today? Download my ebook. The link is waiting in the show notes. And remember, this is general advice only. Always speak to your practitioner for anything medical. See you next time.